Oh, there we go. All right. Hi, everyone. Thank you for joining us today on this lovely Wednesday during your lunch break. And so today we have Bill, who's going to be talking about some healthcare sustainability things. I actually just came back from vacation, so I don't actually know specifically what your topic is. So you're going to have to introduce yourself on that one. But I'll hand it over to you, Bill. And Pam is also here. She's going to be joining as well.
Thanks, Sean. So we are presenting today on better care for your patients is actually also better for the environment. And so we're going to go over with a quick overview and then going to focus on unnecessary diagnostic testing, both blood work and imaging. If there's time, talk a little bit about life cycle analysis of medications, and then Pam's going to talk about urine cultures and contact precautions. So just to give us some background, 8 to 10% of US greenhouse gas emissions come from healthcare. That works out to be almost 2 tons of carbon dioxide equivalent per person every year, which is ridiculous. It's the highest amongst all industrialized nations. And the most recent available data suggests that this amount of emissions continues to increase. The emissions from US healthcare are greater than the entire emissions of the whole country of the United Kingdom. But it's not just emissions. US hospitals generate on average 6.5 tons of waste every
How
day.
many nurses does it take to?
Uh, a big medical center like the one I worked at generates 17 tons a day, just a staggering number. It's basically 2 semi-trucks worth of waste going off the dock every single day. And we spend a big amount of our healthcare dollars, almost $6 billion in 10 years ago, on waste management alone. And it's not just we create waste, but the way we work in this country is very wasteful. This is a study published in 2019 looking at 4 different sites doing cataract procedures. And they did an audit and found that 45% of drugs by volume that were open in every case were unused and thrown away. And it was mostly eye drops. They have multi-use vial eye drops, but their internal policies allowed them only to use those for a single patient. And they found that they were wasting $37,000 to $190,000 worth of drugs per site every year on cataract procedures alone. $40 to $200 per case, 60 to 30 kilograms of carbon dioxide equivalent per case. And this kind of stuff we do throughout the way we practice. Other countries would find this unbelievable. And this is another study done out of University of California, San Francisco, where they looked at surgical supplies that were opened in neurosurgery cases and not used. And they found that about 13% of supplies were left unused at the end of every case, almost $1,000 worth of materials. And those photos are actually a photograph of a couple tables of what was opened at the beginning of the case and never used. Just ridiculous that we manufacture stuff, purchase it, put it on a table, and then just throw it away. And they were losing almost $3 million a year in these wasted supplies at UCSF. And again, this is a real problem with how we practice medicine in this country. And it doesn't have to be this way. This is an interesting study that was published by a couple of leaders in healthcare sustainability. And they looked at a eye institute in India that provides care equivalent in quality to that in the United States. And they provide that care at 1/10 the cost, 1/10 the solid waste, and 1/20 the carbon emissions of what we do here in the United States. So clearly, you can provide excellent care without being so thoughtless and wasteful. So Pam and I would like to propose that more efficient, less wasteful care is actually an overlooked strategy to improve healthcare sustainability. So we can be more efficient in how we care for our patients, and will frequently actually improve patient care and save money and save resources and save the impact on the environment. So first, going to talk about lab and imaging tests. So this paper looked at blood and imaging tests ordered in the first 24 hours of patients admitted to internal medicine from the emergency department. They reviewed 177 charts, and the reviewers judged each test ordered in the first 24 hours of whether it was necessary or unnecessary, and they based that judgment on published clinical guidelines or up to date. And they found on average, patients had 9.2 tests ordered in the first 24 hours, and approximately 1/3 of those were deemed unnecessary. And if they looked at of all patients, 88% of patients had at least one unnecessary test. So this is incredibly common. Only about half of the tests led to any change in management. And for any single test, only about 25% was deemed to benefit the patient. 75% either were of no benefit, or a couple were even harmful outcomes to the patient based on those blood tests. And this is a slide looking at the most common unnecessary tests. And not surprisingly, PT-PTT is right at the top, but it's also liver function tests, urinalysis, and lactate. About half of those were deemed unnecessary for the patient's admissions. And for imaging, not quite as high percentages, but chest x-rays, almost half of those were unnecessary. Low extremity ultrasounds, about 1/3 were unnecessary. And head CTs and EKGs, about 1/4 of those were unnecessary as well. And this is another study out of Australia looking at vitamin D testing. And the authors postulated multiple clinical concerns that would warrant vitamin D testing. But then they looked at all the vitamin D tests in Australia in the year 2020 that were funded by their Medicare system, and they found 4.5 million of those tests, 2/3 of which, 3/4 of which had no health benefit, at a cost of $87 million and 28 metric tons of carbon dioxide equivalent, which is like driving between 160 and 230,000 kilometers. So not only are these blood tests financially wasteful, but also do have a significant impact on the environment. And this is a study. It's hard to find good data on incidental findings on images. This was based on studies that were done as part of research examinations. And they found that 40% of the studies had at least one incidental finding. And if they used ultrasound as the baseline, they found CT of the abdomen and pelvis had about 20 times more likely to have an incidental finding than ultrasound. CT of the chest about 12 times more likely, and head MRI 6 times more likely. Fortunately, only about 6% of those incidental findings generated any clinical action. However, of those 35 or 6% that were evaluated further, over 80% had no benefit to the patient, and almost 10% actually had a clear harm to the patient by working up those incidental lomas. So who cares? Why should we worry about unnecessary testing? There's a reason to worry about that other than the environmental cost. And it turns out, yes, these unnecessary tests can be dangerous for our patients and certainly are expensive. They can lead to the diagnostic cascade. So you find an abnormal lab value or an abnormal finding on an image that you weren't expecting, and that frequently leads to further testing, which is usually uncomfortable for the patient, whether it's more blood work or another scan. It's clearly inconvenient for the patient. It causes expense to the system. And if it's a radiographic study, it leads to radiation exposure for the patient. Even more concerning is these incidental findings can lead to further evaluations, such as a biopsy, which in and of itself can have complications because that's an invasive procedure. And sometimes this will further lead to some sort of treatment or intervention for this incidental finding, which subjects the patient to potential side effects and complications from that treatment or intervention. And this is kind of a goofy slide, but this is kind of an interesting soft paper. The author sent surveys to about 900 physicians, got answers from almost 400, and asked them about the clinical cascade after incidental findings. And over 90% of the physicians who replied to the survey, 371 physicians, said that they had patients who did enter the clinical cascade after an incidental finding. And then the author asked them to judge the most recent clinical cascade that they could remember and ask whether it led to harm to the patient or the physician. And the harm to the patient we discussed. For harm to the physician, they talked about anxiety or increased work. So kind of a squishy endpoint. But nonetheless, these physicians said 83% of the time following up an incidental finding led to harm to either the patient or the physician. So in addition to potentially starting the diagnostic cascade with unnecessary tests, which can lead to clearly increased expense and potentially increased complications for the patient and discomfort for the provider, every test we do has an environmental cost in addition to its clinical costs. So it requires resources and energy to do these tests. For example, for imaging, the axial images, CT scans and MRIs, use a large amount of energy per scan. And the CT is an order of magnitude more than an ultrasound, and MRI is an order of magnitude greater than a CT scan. The emissions from a single abdominal MRI are equivalent to driving a car about 180 miles. So there is an environmental price to pay for doing these tests when they are unnecessary. So what to do about it? Well, this is a paper that looked at evidence-based guidelines to eliminate repetitive laboratory testing. So it's a review article and looked specifically at patients getting daily labs over and over again when they're inpatients. And they start out by stating that repetitive testing in the face of clinical stability is of low value. That's been documented in multiple studies. And they said that has some risk to the patient. And they said one of the risks of excess phlebotomy is anemia. And I thought that was maybe a bit of a stretch. So I actually looked to see if there were actually any data to support that. And it turns out this is a study that looked at 400 admissions. The average decrease in hematocrit across those admissions was 2.1%, and the average phlebotomy volume was 75 milliliters. They did a multivariate analysis and found that the volume of phlebotomy, in fact, did predict an hematocrit drop, and 100 milliliters of phlebotomy correlated with a 1.9% decrease in the hematocrit, suggesting that our patients are paying a clinical price for getting tests that might be unnecessary. And this is a much larger study looking at 17,000 patients who were admitted with myocardial infarction and looking at hospital-acquired anemia, which they defined as a hemoglobin concentration of less than 11 grams per deciliter. And they found that patients who had hospital-acquired anemia had on average twice as much phlebotomy as patients who do not have hospital-acquired anemia, and that was highly statistically significant. And they found that for every 50 milliliters of blood drawn, the risk of anemia increased by 18%. So it looks like repetitive testing does cause anemia, potentially, and also obviously leads to increased costs and the potential for further unnecessary tests and procedures. So the authors further posited that reducing testing will make your patients happier. Getting less blood tests and less x-rays while you're in a hospital are going to make you happier. Clearly decrease costs, and they stated that this has been shown to have no negative health effect based on the studies showing that repetitive testing in clinically stable patients is of low value. So with those assumptions, they went ahead and reviewed the literature on mechanisms to decrease the incidence of unnecessary repetitive laboratory testing. And they found some resources suggesting that educating providers reduced avoidable tests from 2 to 1.6 per day, which was significant, but that was not sustained, not surprisingly. An audit where they actually measured the number of unnecessary tests and feedback to the providers, how many unnecessary tests they're providing, was more effective, leading to a 10 to 66% reduction in testing. And using an EMR-enabled restrictive ordering where you could not order tests that did not meet certain criteria, led to a 12 to 20% reduction. And of all the efforts, this seemed to be the most sustainable, but clearly the most onerous also to the providers. So the authors concluded that if you want to decrease unnecessary inpatient laboratories, a combination of education, auditing, and feedback, and some EMR restrictions is probably the most effective way to do this. They all have their advantages. And then finally, I'm just going to talk a little bit about the life cycle analysis of medications. It turns out that prescriptions account for about 15% of the entire greenhouse gas emissions from U.S. healthcare, based on a definitive study published by Eckelman in 2020. So this is important. How we choose medications can have a significant impact environmentally. And I'm going to use a pretty obvious example, which are metered dose inhalers. And we've talked about this before. These are a problem because they contain a propellant, hydrofluoroalkane, which is a very potent greenhouse gas. In fact, the propellants from metered-dose inhalers account for 0.03% of all greenhouse gas emissions. A tiny number, but a pretty significant thing from one medicine across the world. And in fact, the National Health System in UK concluded that 3 to 4% of their healthcare emissions were just from the propellants in metered-dose inhalers. And the effects in the United States of metered-dose inhalers are about the same as 500,000 cars on the road for the entire year, not just, you know, 500,000 cars, but for entire year. So this paper looked at the carbon footprint of metered-dose inhalers versus dry powder inhalers, which have no propellant, or soft mist inhalers, also which have no propellant. The soft mist inhalers have a little spring in the device. The dry powder inhalers are just a chamber that contains the powder, and the patient's inspiratory force pulls that into the airways. And this is a European study, so all these options are not necessarily available in the United States, but nonetheless, this is the best study I could find on this issue. And they looked at the entire life cycle of metered-dose inhalers versus dry powder inhalers versus soft mist inhalers, including the raw material extraction, production, packaging, distribution, clinical use, and then end-of-life disposal. So really a full life cycle. And these are the results of the study. And just to go through this, basically all of this is the carbon footprint on the y-axis, and all of the big bars are metered-dose inhalers. These two small bars are the dry powder. These are all dry powder inhalers, and these two are soft mist inhalers. So you can see the carbon footprint per month is substantially lower for dry powder inhalers or soft mist inhalers versus metered-dose inhalers. So if you have the option for your patient, switching them from a metered-dose inhaler to a dry powder inhaler or a soft mist inhaler will have a significant benefit on the environmental impact. And again, similar evaluations can be done with other medications if you can find literature to support that. And just one other life cycle analysis of metered-dose inhalers, and this was done versus nebulizers. So I know we've had this discussion previously with Amanda and some of the pediatricians that they, for years, have worked to get their kids off of nebulizers and onto metered-dose inhalers. And this is basically looking at nebulizers for home use. So they assumed a single inhaler provides 100 doses, 2 buffs, and that a nebulizer would be used for 2 to 4 treatments per week. The compressor would last for 10 years, and then the mouthpiece and delivery components would be cleaned and reused. So this is not an analysis of how a nebulizer would be used in the hospital, but how it would be used at home. And they looked at the whole life cycle. They cradle to grave. So they looked at everything on the manufacturing metered-dose inhaler, looked at the manufacture of the nebulizer and its components for delivery, the mechanical device and everything. And they found that per dose, the metered-dose inhaler had the carbon dioxide equivalent of 2 to 3 times that of the nebulizer. So from an environmental standpoint, using a nebulizer is much more favorable than a metered-dose inhaler. And then this is just that in graphic form. So this is kilograms of carbon dioxide equivalent on the y-axis, metered-dose inhaler, nebulizer if you use a dishwasher, nebulizer if you hand wash. And as the data have shown for dishwashers for your dishes, they're actually better than hand washing your dishes based on water and energy use also. So that is all I have to present, and I'm going to turn it over to Pam at this point. And we'll if we have questions, we'll do those at the end.
Okay, thanks, Bill. Can you all see my screen?
Oh, that's good.
Okay, so I had my camera off because I am actually in my childhood teenage bedroom at my parents' house, and I decided to make a very bold choice as a 16-year-old and paint my room this like incredibly nauseating green. It's a little better in person than it's showing up on the camera right now. Unfortunately, I'm here because my dad, it seems, has a new diagnosis of polycythemia vera. And actually, as Bill was talking about anemia from phlebotomy, I was kind of going like, I need to get my dad some of that. I need him to undergo a little bit of a phlebotomy right now because he's got a hematocrit in the 60s. But that's an appropriate use of testing, and that's not what we're here to talk about. We are here to talk about ways that we can improve patient care while also keeping sustainability in mind. So I'm going to be talking about practical approaches to environmental sustainability and infectious diseases. For those of you that don't know me, and I think we actually have a lot of people on here who've been on a lot of our meetings. And my name is Pam. I'm an infectious disease specialist at Harvard UCLA in Los Angeles. And my academic interest is environmental sustainability within healthcare with a focus on infection prevention and control and diagnostic stewardship. So when we talk about sustainability and patient care in general, we come up against this concept of low value care a lot. And this is a lot of what Bill was talking about, right? So how do we define low value care? Well, as you can see in this figure, which was developed by Jonathan Sletzman and Greg Fury, with whom I presented at CleanMed this year, they define low value care as unnecessary or inappropriate care that does little to improve clinical outcomes and potentially causes harm. And on top of that, it also incurs avoidable financial and environmental costs. So there's some really important words in there, right? Unnecessary, inappropriate, clinical outcomes, harm, and avoidable. So all of these things are things that we can improve and co-benefits to also improving the sustainability of our patient care. So not sure. Oh, I can't open the chat. Okay. So we're gonna make this presentation everyone's favorite word, interactive. So first question for everybody. Have you seen low value care conducted at your place of work? Feel free to speak up or raise your hand. I will raise my hand. I will raise both hands. Yes, emphatic yeses. All right. Have you personally practiced low value care? I will also raise my hand for this one. I think it is hard to be a physician in America and not practice low value care at some point. Okay, so since we are all sort of on the same page there, we all acknowledge that we have either experienced, seen, or personally conducted low value care. Let's talk about some ways we can improve it. So I'm going to X out of the chat, but please feel free to speak up or someone else let me know if there are questions in the chat. All right, so why are we focusing on infectious diseases besides it being my specialty? Well, one point that I'm going to come back to over and over is that we do have an overrepresentation of infectious disease related diagnostics and treatments in this low value care quadrant. And on top of that, we also, I have this later, we also have some infrastructure to address that. So those are two really good reasons that we're going to be talking about this. But one thing I want to emphasize is that as we've just seen, low value care exists in every aspect of healthcare. And I'm sure that many of you are thinking of ways that you have seen or practiced low value care yourself. All right, so let's get into a case. We have a patient named Mr. C. He's 73 years old. He has hypertension, diabetes, and dementia. He's coming in from a skilled nursing facility with altered mental status. At his baseline, he is alert and oriented to name only. On exam, he's afebrile. He has normal vital signs. He's alert and oriented times 0. As part of an extensive workup, urinalysis, blood, and urine cultures are ordered. The urinalysis comes back first and is normal without signs of infection, but then his urine cultures grow vancomycin resistant Enterococcus faecium. All right, who thinks urine cultures should have been ordered? All right, so we got some no's in the chat. Excellent. Okay, so I totally agree. So urine studies done to diagnose UTI are a great example of low value care. Why is it low value care? Well, there are a few reasons. Number one is that we know that these tests are highly nonspecific. So the prevalence of bacteria or white blood cells in urine without a concomitant UTI is very high. So you can see this chart from the Agency for Healthcare Research and Quality that in patients like the one that we discussed, those are that are in long-term care facilities, the prevalence of things like asymptomatic bacteriuria approaches 50%. For patients who have things like indwelling urinary catheters, that prevalence rises to close to 90%, or potentially up to 100%. So you can see that these are just not great tests. They are non-specific for diagnosing UTI. On top of that, we do also know that treating these patients with antibiotics does not improve clinical outcomes. So for that reason, guidelines recommend against screening urine for infection in asymptomatic patients outside of very specific situations. So moving on with our case, he is placed in contact precautions and he started on intravenous linezolid. You determined that his altered mental status was due to a medication error, and he returns to his baseline mental status at hospital day 4. His discharge is then delayed because his sniff now goes, you have him in contact precautions there. We want him in contact precautions here, and we don't have the right kind of room. So then he remains hospitalized for 7 days in total. During this time, 200 single-use disposable gowns are required in his care. I'm sorry, Bill, you had your hand up?
I don't know if you want interruptions in the middle, but
Yeah, okay.
you didn't say anything about the colony count on the
Mm.
urine culture. Does that make a difference?
Yeah, the CFU count. So it can. The problem is that CFU count is highly subject to processing. So if you have urine that has been, say, sitting at a bedside table for a number of hours, I think it increases exponentially just with sitting at room temperature. And a lot of the time, unfortunately, what people do when they collect urine, especially in catheterized patients, is they will just take urine out of the Foley bag, right? Which is problematic for a number of reasons. But in this situation, it would be because the CFUs have gone up and up and up while that Foley bag has been sitting there. I think a lot of people like looking at the CFUs, right? For me, as an ID specialist, it matters a lot more whether or not the patient is symptomatic, whether they have systemic signs of infection, and also the type of bug. There are certain bugs where I would go, it's 1,000, but it's very typical, and you've got someone who's very symptomatic, I would probably just treat it. But then there's absolutely patients where it's, 100,000 CFUs of something that is not a pathogen, likely skin colonization contaminant. And it doesn't matter, it could be 1,000,000. I'm still not going to treat it. Yeah. Okay. Anything else? All right. All right. Next question. And I don't know the answer to this question, but I kind of like to ask it because I think it's interesting to see what people say. Among the following, what part of his care had the highest environmental impact? Was it the 5 days of linezolid? Was it the daily labs? We just talked about the labs and how bad they are and they're making everyone anemic. Or was it the gowns? What do we think? Okay. I should stop having Bill answer first, is what I'm getting from this. All right, everyone wants to blame the gowns, and that's not a bad guess. So I will say I would suspect that the gowns have a higher environmental impact than the daily labs. Linezolid is a big old question mark. So how antibiotics are manufactured is number one, we don't have a lot of information about it because it's up to the manufacturer, but there's two sort of general processes, either synthesis or fermentation. So getting a big vat of bacteria and they ferment the antibiotic. And that has been shown to have a relatively high environmental impact. That being said, I really don't know. The linezolid, it's a very complicated structure. I think it takes like 2 or 3 days to synthesize something like that. It probably has a high environmental impact, but we don't know for sure. People always zero in on the gowns though, so that's kind of interesting. All right, so now that we've gone through that case a little bit, and I would, by the way, suspect for anyone working in a hospital, that was not an unusual case to you. You're probably going, I admitted someone like that 2 days ago. So now that we've talked about that, we're going to talk about where are there opportunities for sustainable changes. Bill mentioned the cascade, right? The clinical care cascade that can occur after an initial round of testing. And the urine culture cascade from a sustainability viewpoint can be quite extensive. So we'll talk about a few different parts of that. So first of all, we have just the urine culture, urine specimen collection itself. So in this study where they looked at geriatric patients presenting with fever, they noted that a lot of patients had non-urinary sources of fever, 75%, but still had urine cultures conducted. On top of that, about 50% of the patients required catheterization in order to obtain cultures. So that's another source of single-use plastic waste that is used and then thrown away immediately after the urine specimen is collected. Bill talked about medications. In ID, we love to talk about antibiotic stewardship. This is a great opportunity for stewardship. People tend to be very reactive, right? When you have a positive urine culture, they tend to want to treat it with antibiotics. So what we know is that around 50% of the time when patients have unnecessary urine cultures ordered, they receive unnecessary antibiotics. I'm not going to keep harping on that. I'm sure all of you have heard things about that from your own ID folks at your institutions. But what I do want to point out is that sort of similar to the inhalers, there are some sort of not as obvious opportunities for sustainable change here as well. And one of those is actually giving oral antibiotics instead of IV. So we know you can just see from the amount of materials required to give an intravenous antibiotic versus giving someone pills, it's a lot more waste, a lot more plastic, a lot more nursing time, a lot more difficulty maintaining the IVs, and all of these other issues that come along with that as well. This study out of Brazil found that by using IV to PO switches for antibiotics over a 3-year period, they were able to divert around 170,000 grams of waste. This is also something that is very much part of the ID community, something that we try to encourage in our antibiotic prescribing as well. So you can see at the bottom there that the Society of Infectious Disease Pharmacists recommend transitioning from IV to PO in order for inpatients who are on antibiotics. The reasons that they cite being that patients have more line-related infections, longer lengths of stay, and on top of that, if you can use the gut, why not do it? I'll say that, personally, I'm always switching things from IV to PO in the hospital. It seems like a lot of our order sets, for whatever reason, tend to favor intravenous. The reasons I tend not to do it are if patients are going back to the OR repeatedly and are going to be NPO, then I don't want them to miss their antibiotics. I don't want them to have, confusion or mistakes with their oral antibiotics because of things like that. But otherwise, a lot of our antibiotics are extremely bioavailable, and we do have the option to give things orally a lot of the time. I'm not even going to get into outpatient IV antibiotics. That is its own mess, and also a lot of conversations going on about that in the ID community. Probably an area we can make even more important sustainable changes. Okay. And then I mentioned this already, right? Stewardship. So a lot of you might be familiar with this idea of antibiotic stewardship, but where the testing comes into play and where the improved care for our patients comes into play is with something called diagnostic stewardship. And that's really what we're going to be focusing on. There is a really nice synergy between stewardship and sustainability. We often like to point out, sort of these similarities between Alexander Fleming, who was, of course, the inventor of penicillin, talking about how the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with a penicillin-resistant organism. And similarly, we had this quote from Dr. James Black, who said, "The most likely manner in which mankind is influencing the global climate is through carbon dioxide release from the burning of fossil fuels." Does anyone know who Dr. James Black worked for? He worked for Exxon, of course. So, there's synergy in more ways than one with stewardship and sustainability, right? And one of the important things to recognize is that because stewardship is now built in to our healthcare facilities, you already have sustainability-minded people at your places of work. So talking a little bit more about this idea of diagnostic stewardship, this is the rational use of laboratory testing to guide patient care. It can also be summed up as right test in the right patient at the right time. It's a clinical quality improvement process, and it's been highlighted as an important mechanism to optimize resource utilization. As we mentioned, it has a lot of shared goals with sustainability, reducing wasteful resource use while maximizing patient safety and health outcomes. And there is this key goal in diagnostic stewardship with ID, which is to improve UTI testing appropriateness. And to look at the sustainability side of this diagnostic stewardship intervention a little bit, we did our own life cycle assessment of UTI tests, urine cultures, and urinalyses at Harbor UCLA. And what we found was that based on the number of tests that we'd run, we were generating about 29.1 metric tons of CO2 equivalents in 2 years. And we know that around 40 to 50% of these tests are done inappropriately, which generates about 3,000 kilograms of solid waste, the bulk of which is plastic waste, around 2,300 kilograms. Unnecessary tests, again. If you want a little bit of a frame of reference, that is about the weight of 6 polar bears. Okay, and then finally, what am I doing on time? All right, we got some time. To get into the gowns a little bit, everyone's favorite topic. So what do we know about gowns and their utility? Well, first of all, we know that a lot of patients have multi-drug resistant organisms, particularly those who have a lot of healthcare exposure, who live in nursing facilities. And we actually know that it is likely that what we are able to culture and what we actually see in our electronic medical record is just the tip of the iceberg when it comes to MDROs. They've done point prevalence surveys of these skilled nursing facilities, demonstrating that colonization with these MDROs is over 50%. And relevant to this talk, most of those MDROs are frequently placed into contact precautions. Now, I mentioned kind of this iceberg effect, right? And what I mean by that is that just the things that we see, those are just part of the MDRO population in the entire facility. So one could argue that when you do these targeted interventions, such as contact precautions, you're only targeting the patients who have known MDRO colonization, right? So you're likely missing a huge amount of patients who do have these MDROs that, according to your facility's policy or whatever, should be placed in contact precautions. So you could say then that likely what we need is not these vertical interventions, these targeted contact precaution-like interventions, but we need everyone to be practicing good horizontal infection prevention practices for everybody. Because again, you don't only want to focus on the tip of that iceberg, you want to focus on your entire patient population. And probably the best way to do that is hand hygiene. So this is a healthcare worker's ungloved hand cultured after doing an abdominal exam of a patient known to be MRSA positive. And this is that same hand after hand hygiene was performed with alcohol foam. So hand hygiene really works. And I'm not talking too much about infection control in this talk, but I do want to say that since Bill and others like to call out infection control all the time as the problem in healthcare sustainability, if you really, really want to work well with your infection control departments, tell them you want to work on hand hygiene. They will love you for it. This is something that synergizes so well with both sustainability and infection control. So to get back to the gowns a little bit, what do we know about contact precaution use for these organisms? Well, we know that for certain organisms like MRSA and VRE, they're very controversial. And actually for decades, people have been arguing that we do not need these anymore. And part of the reason for that is that the efficacy of these contact precautions at preventing transmission is actually thought to be relatively low. We recently looked at contact precautions use in LA County, and what we did was survey all of our different facilities, and we had a pretty high survey response rate, over 80%, and we looked at which conditions they used contact precautions for. So you can see from this that use of contact precautions for MRSA is still relatively high across LA County, around 75%. And then we stratified these different contact precautions use into these different categories. And then we performed a multivariable analysis looking at the relation of contact precaution use to the rates of MRSA bloodstream infections. And you can see from these top rows that our model did not find an association between higher rates of MRSA bloodstream infection and level of contact precaution use. Now, many of you may point out lack of a finding is not a positive finding, and that's absolutely true. But what we did see in our model was that long-term acute care hospital patients have a rate of MRSA bloodstream infections that is 3.5 times higher compared to patients in general or critical access hospitals. And that is a relationship that is known to exist, okay? So even though, again, we don't have a positive finding here, we have a lack of a positive finding, we are able to establish that our model is able to detect relationships that do exist, which adds some credence to the results that we have here. So on top of these contact precautions potentially not being that useful, we also know that patients who are in contact precautions have more adverse events. So this was a study that was done out of Spain, and what they found was that patients who were isolated had a significantly higher rate of adverse events compared to those who are not. And actually, healthcare associated infections were the most common adverse event. And more of these adverse events, more than half of these adverse events, were actually preventable. So, this is one among a number of studies looking at the differences in adverse events between isolated versus non-isolated patients. The and there is, I would say there is a trend within the literature. The major criticism of these studies, just to call it out immediately, is that there are probably differences in comorbidities and patient population between the two groups. That being said, there is at least a suggestion within the available data that this is something that we do see. And I think on top of those medical adverse events, there's other things to consider. So this is a photo of Princess Diana in 1991 shaking the hand of a patient who'd been diagnosed with HIV. And this photo went, whatever the word for viral was in 1991, because this was just something that wasn't done, right? This was a time in the AIDS epidemic when there wasn't as clear information about how these diseases were transmitted. But the reason this went viral was because Princess Diana was, known as a humanitarian, and this just showed her willingness to help this patient feel normal again, feel like they were not someone who was diagnosed with this transmissible disease. And I think that that's really important to think about, right? When we're placing patients in contact precautions, when we're using gloves on every single patient, regardless of if they're in contact precautions or not. And this is something that has been looked at a little bit in the infection control literature as well. And patients do report that when they're in contact precautions, they feel like they are not just the patient, but they are also the disease. So just to recap, patients don't like these contact precautions. They probably don't work. I would guess that most providers don't like contact precautions. I know I certainly don't, and that's not just because of the environment. Unfortunately, the infection control community is still working on coming to a consensus about a lot of these contact precautions. The CDC actually sort of recently doubled down on contact precaution use for MRSA. That being said, I think it is something that many of us who are in infectious disease and also interested in sustainability, are very eager to change for a number of reasons. And I presented these data before, so I'm not going to get into it too much. I don't think it's any surprise to anyone on this call that contact precautions for MRSA and VRE confer a significant environmental impact. In LA County, we've actually taken the step of suggesting to many of our healthcare facilities that they do not use contact precautions for MRSA and VRE. If you're interested in learning more about that, I have a website linked down at the bottom. So I think to close things out, I would love to hear from everyone. Where are there opportunities for sustainable changes in your place of work? And on top of that, how might those sustainable changes also benefit your patients? Let me look at the chat real quick. Yes, the contact precautions frighten patients' family. Absolutely. Bill does not work. Okay, so Amanda pointed out lab testing. Do you think you could speak a little bit more to that, Amanda? Are there labs in particular?
Sorry, it's quite loud where I am, so I apologize for background noise. I am relatively new to attending at our my local children's hospital in our teen clinic, and there seems to be a habit of repeat, these are, teenagers to young adults. They've had, metabolic labs, including vitamin D and a whole host of things. There's some mild abnormalities. And it tends to just seem to be the pattern. And sometimes I fall into this totally myself, where we just are repeating those labs. And again, the cascade, like once you're poking the patient once, you might as well okay, let's just recheck the vitamin D. Let's just do this. Let's just do that. So this is something I need to do, is figure out and refresh my knowledge of what I guess it's AAP is actually recommending in terms of the frequency of checking and rechecking metabolic labs. But that's, I think, a huge place for me personally.
Absolutely. And there's also some data to support that, right? As Bill mentioned with the vitamin D study. So I think that's a great suggestion. You know, a lot of our lab testing occurs in the outpatient setting. Urinalysis and urine culture is actually in my system. I think somewhere around like 60 to 70% is outpatient. So I think that's a huge opportunity. Okay. Oh, Jeff brought up a great point about patient's insistence. I don't know if Jeff, you're able to come off mute as well, or I could also talk about patient's insistence. I'm sure all of us could.
Yes, no, I'm off mute. Yeah, no, I can't even tell you how many times a day I am, I hate to say fighting with patients, but certainly there's a little disagreement about getting MRI scans and how do I know what I'm talking about if I haven't had an MRI scan. So, I certainly order too many, but I also do talk people out of them and I'll tell them why I don't think they need an MRI scan. And I'll say if they still hurt, to get an MRI scan. But also, probably a lot of people, probably way more people come in with an MRI scan that I don't think was appropriate, ordered by the emergency, by somebody who is well-meaning and wants to help out, but it might not be necessary. So, I mean, part of it is on us, of course. We should be ordering appropriate tests, but also patients, a little bit is on them, and they are often think that they know more than they do. They've looked at the internet, how and they've seen some studies and things like that. So that's always contentious for me. And I won't even get into the OR, Brenda. That's like 10 times more. But MRI scan is probably something that a lot of us that happens, to many of us.
Absolutely. And I think, something that's important to point out is, like you mentioned, you talk people out of these scans and you are a very sustainability minded person, right? You probably have there are probably so many other providers in various different areas where they're like, okay, fine, I'm just gonna do this MRI because it gets my appointment over quicker. I can move on, do all of these other things I need to do.
Yeah.
And we've all been in that situation. It's even knowing the data, um, it's hard to really kind of commit to the sustainability or the high value care mindset when you're like, man, I just want to go home. Let's see. Yes. Oh, the wrong test. That's actually a great one, Brenda. So I was just talking to one of our radiologists about there's some sort of AI program, and I know AI and sustainability don't necessarily go hand in hand, but what it does is I guess it looks at scans to determine if the quality is good enough. And it can do that kind of in real time so that the patient doesn't have to like leave and come back for a new scan. So I don't know. I haven't looked into that in too much detail, but people are thinking of some creative ways to approach this. Mm, mm, Laura, that's a great point. I don't know if you want to come off mute as well.
Hi. My specialty is with kids in pediatric neurosurgery. So I feel like it's a lot of parent education and a lot of fear and anxiety. And I just wanted to comment that parents are well-meaning. I think all patients are well-meaning, but unfortunately, fortunately, I do have the time that I'm often able to sway parents away from unnecessary imaging, but it requires a lot of time and a lot of education. So it's hard. It's a lot of resources because people think they know, and to be able to redirect people in a kind way is really, really challenging. That's all.
No, that's great. I love that both you and Jeff have kind of honed in on this idea because it is one of our biggest challenges. Bill, you have your hand up?
Yeah, just something that is germane to this discussion a bit is an area where one might have a systemic opportunity for improvement is in what's getting ordered in the emergency department. So I didn't focus on this, but in one of the studies I quoted, the first study I quoted, many of the studies that were considered unnecessary were not ordered by the admitting physician, but were in the emergency department. And many of those doctors admitted that they would not have ordered those. And also some of them said they didn't even know the patient had had that test done. So if we were trying to figure out a way to decrease unnecessary tests in a system or in a large hospital, getting the emergency medicine folks involved is important, because a lot of stuff, I mean, I certainly saw this in my specialty, that they would order imaging tests on my patient's blood vessels that either wasted time for a patient who had an acute ischemic event, or was a wrong test, subjected the patient to a bunch of contrast that they didn't need when an ultrasound was suffice, stuff like that. So that is a concern that's difficult to handle, but a potential opportunity.
And, to plug stewardship further, these are things that we've been talking about for years, right? We've been saying, like, you don't got to give the vancomycin immediately. You don't have to do this. You don't have to do that. Okay. I love all the interaction. Roz, you have your hand up?
Yeah, hi. I work in a radiation oncology department. I'm a medical social worker, and I looked up on NIH, what are some sustainability approaches that have been studied. And there's two or three that I think would be interesting to bring to my department, but as a non-medical person, I don't feel like I have any credibility. I mean, in terms of, like, for instance, one of the things about radiation therapy is that people are coming 5 days a week, traveling. Actually, the emissions of the transportation 5 days a week for multiple weeks is the biggest climate impact of radiation treatment. And so there's suggestions about, prescribing shorter courses of treatment that are just as effective. There's a study about it. But I just feel out of my depth to bring that, to suggest. Obviously, I don't even know how to talk about it with them, with the doctors. So similarly, there's something about masks, the plastic thermoplastic masks, and not using them in certain cases, and an creative approach to not using those. And same thing, I just I'm not really sure how to bring that up with my team.
Yeah, so I think we may be connected on Slack a little bit, Roz. Wonder, Bill, maybe we can reach out to Roz and kind of help her develop some of these ideas a little bit more, and maybe try to find some good allies within your department. That might be the first step.
Thanks.
Yeah, of course. I know you've been kind of trying to get some of these projects off the ground, so I that's kind of mine and Bill's job, is to support people like you.
Thanks.
Okay. Oh yeah, Katie Lichter is a great idea. Yeah.
I think she is a radiation oncologist. I think she, I
Yeah.
don't know if she graduated or not. But
No,
yeah,
she's in her last year residency.
she's in her last year residency. Okay, but yeah, she could be interesting to talk to, Roz, because she would know how to talk to other radiation oncologists. And they've done some interesting stuff at UCSF, I think, with trying to use like Uber Green, which is where you're like guaranteed an EV to transport their patients back and forth for daily radiation. So they pay for that. But yeah, she could be an interesting resource.
Okay. Oh,
Yeah.
thank you.
Yeah, no problem. Okay, so just in the last 3 minutes, thank you everyone for joining, and thank you so much, Bill and Pam, for always being these amazing guides, and like the sessions that you guys run, I know, are some of our most popular sessions, because I think a lot of people are really, really interested in how, just where you work. Like, it should be simple enough, right, to change things in your workplace where you are for the majority of your day. But we all actually know that it's really, really challenging. And so, in case you guys didn't know, Bill and Pam, not only are they the co-leads for our healthcare sustainability team, and they put on these education series about like timely and practical healthcare sustainability topics, but they are actually, more importantly, the coaches for our fellowship, our healthcare sustainability fellowship, which is this amazing 1 to 2 year long commitment where you get Bill and Pam to guide and support the completion of sustainability projects of your choosing. And so then this is done by a lot of our CHN members. And so this year, when we will launch, we have 3 teams that are doing different projects, focusing on things like, like food or waste in the pain procedure suites, or, OR scope 3 reduction. And so it's a variety of things. And we know that there's like no other fellowship in the nation like ours, which is also amazing. And Bill and Pam, give their time to be able to support our membership on doing these projects. And so to help our fellows be more successful, we are fundraising this month to provide a stipend for the fellows, so that they can attend this annual national education meeting around healthcare sustainability called CleanMed, and also, to have an annual meeting where they can also learn from each other and share their results. And so what we are fundraising right now, all of it goes to the fellowship. It's not going to be used for any other CHN programs, just the Healthcare Sustainability Fellowship. We are aiming for $20,000. So if you are able to give, it's a tax deductible donation. We would be really, really grateful. But even if you can't, if you know others who maybe, really are passionate about healthcare sustainability, but don't have time to attend our sessions, or, would like to support us in other ways, we would really appreciate that. And I think Amanda is sending out an email, probably going into your inboxes right now. And so if you forward that along and just share the fundraiser, that would be really amazing, and would help us a lot to be able to ensure that our fellows do, get the most out of it. And we also are going to be releasing the applications soon, like in the next month or two. So look out for that if you also want to actually come and apply for one of these spots to be one of the fellows. And so they are in teams. We do think that having a team in the workplace is definitely vital for success. Otherwise, we also have a Slack channel. If you guys are a Slack specifically on healthcare sustainability, Amanda can put the link on the chat in case you would just like to, ask questions and be around like-minded people virtually. That's always there. And, sounds like all of you are very interested and would be really great. If you aren't already on the Slack, it would be really great to have you there. So yeah, I think that's it. We are at time 1:30. So again, really appreciate everyone for joining today. And we will see you next time. Thank you.
Hi,
Amanda,
everybody.
could you put the Slack link in the chat? Would
Oh,
you mind?
yes, there it is.
Or is that the best way to do it, or?
Yeah, yes. That if you click that link, that should work. Megan, if that doesn't work for you for some reason, just let me know and I'll send it to you a different way. But
Okay,
that
let me
should-
see if I can.
That should.
I'm on like a funky work computer, so.
Oh, there may be like paywalls and stuff,
I don't know.
but
Let me see if I can just
know.
copy the link though. I can deal with it later.
Okay.
Okay, awesome. Yeah.
Okay. All righty. Bye,
Thanks for sharing that.
everybody.
Bye.